Hello. I'd like to talk about my approach to people when I first meet them after they've presented with a hip fracture. That's experience based on well over 10,000 people over the last 3 decades. I'm not going to go through the issues of clerking and surgical assessment, just to try and bring some of the additional areas where an orthogeriatrician assessment and an orthogeriatrician's thought processes might be a useful addition. What do I need to tell them? Well, whenever you're challenged to tell people something, or to break bad news, or to consult with a patient, what you don't need to do is tell them anything. What you need to do is to get them to tell you things so that you can understand them as an individual and them as a personality, and actually so that you can build up that relationship with them that allows them to trust you and to guide you through the rest of things. So the first thing that I do when I meet somebody is ask very simply, how did you break your hip? Trying to get across to them the point that they have broken their hip, and then leaving it to them to give me free text, to give me a description of the events. Sometimes, alarmingly, that means that they said, well, 30 years ago, doctor, I had this, and you can envisage a very long and protracted description of the events leading up to the hip fracture. But generally, I try not to interrupt people and try to just let them flow with the description, because often they've been challenged by people who have vast amounts of paperwork and huge numbers of preoperative questions, assessment questions to fill, and they haven't really had a chance to tell their story. And the longer somebody's in hospital, the more they tend to edit the story that they're telling you to fit with the way in which they've told it to previous people. So giving them the opportunity to tell the free story is a hugely powerful way of getting a real sense of what happened, because knowing why they fell and opening the door on the assessment of falls, the reasons for this, was this an accident, was this something that was due to intrinsic problems with gait and balance, was this something due to some underlying loss of consciousness, etc., etc. All of that comes out beautifully if you just give people time to tell you the whole story in their own words before you start questioning them in detail. But the other thing that happens while you're listening to somebody talking to you is that you're starting to do a comprehensive geriatric assessment. You're checking and reminding yourself to check that you want to know what their hearing's like, what their speech and language are like. Is there evidence of cognitive problems, hesitancy, difficulty with memory? Do they seem as alert as they should be? Might the analgesia that they've already had be inappropriate? Might there be concerns of delirium? Are they paying attention to the story? Are they able to continue holding the story together and focusing on the questions that you've been asking? Or is there a suggestion that they might be developing delirium? What can you see about their mood and get a sense of how their mood has been in the past, and how that might have implications for their recovery and their ability to cope with the major event that's suddenly presented to them? What fear and anxiety is evident from their story, because fear and anxiety about getting out of bed, getting back onto the feet, about handling pain are all going to be major challenges over the course of the next few days for them. So understanding that from a very early stage is important, and watching how they move in bed and how they respond to questions will also give you a sense of their ability to deal with pain, and how they're responding to the analgesic approaches that they've had or that they currently need. So all of that goes on very quickly in really just the first question in talking to somebody, and is hugely important. There's an enormous amount that you can tell people about their prospects after a hip fracture, and I don't plan on making this a long and protracted talk by going through all of the elements of advice that you might be able to give people. But you really should have some form of advice sheet available so that you can give this to people so that they and their families can understand what's going to happen ahead of them. And having a pre-printed sheet that allows you to show them the sort of fracture that they have and to give them an indication of the sort of surgery that they might have is very attractive. So this downloadable Word version of a document is something you could consider adapting to your local circumstances. The process of consenting patients should take them through all of that, of course. Before signing consent with the surgeon for the operation that they're going to have, they should be made aware of the likely events in theatre, post-theatre, and the potential risks of having surgery. And of course, when I read these consent forms, they invariably list infection, bleeding, and pain, but they don't really go into any great detail about that. I think in talking to patients about pain is really important, because the surgery they're about to have is going to change the pain they've got. It's not going to take away pain. It's going to change them from an instant pain of two pieces of bone grating against each other and causing an excruciating pain that is sudden and severe and not really amenable to opiate analgesia, which is why we use nerve blocks. And it's going to change that to a post-operative pain that is more of a bruising and more generalized. It's there more when they're at rest than perhaps a fracture pain might be, and is exacerbated when they, as they need to try and get out of bed. So you need to be explaining about the need for analgesia, and particularly analgesia given before they start trying to get out of bed, timing analgesic doses in the post-op period so that when they and the physios are working together in the first days, there's additional analgesia, which is a topic for another talk. So pain is often mentioned but not really explained. And explaining it, an explanation, and allowing the patient to know what's going to hit them in the post-operative period stops them being frightened when they wake up after surgery, which they thought was going to solve their problems, and actually they're still in pain. And dealing with the fear of pain is half of the challenge of dealing with pain itself. The thing that's never on the consent form, or very rarely on the consent form in most hospitals, is the commonest complication of having a hip fracture and having surgery and anaesthesia for it. It's delirium. So while rates of infection in the wound and bleeding from the wound may be less than 1%, the rates of delirium are enormous, but nobody ever tells patients about it. This really does need to be something that's on the consent form when you're consenting a patient. And that's not just for people who are competent to consent. So in the brilliant paper by Mark Antonio, which I use in my delirium talks and my delirium teaching, even among consenting patients who were able to consent to be in his randomized controlled trial of usual care or comprehensive geriatric assessment as a way of reducing risk of delirium, 29% of people who were able to consent to be in that trial developed severe delirium in the control arm. So even in the consenting group of patients, delirium is by far and away the most important complication of hip fracture surgery, hip fracture anaesthesia. But it's not something for which patients are consented, about which they're warned, and it can therefore be extraordinarily frightening. So getting that point across at an early stage is hugely important. Of course, if you're doing a consent form 4, if you're consenting somebody by talking with their relatives, their carers, because they have cognitive problems and memory difficulties, communication problems that make it impossible for them to consent for themselves, you don't need to be consenting them for the likelihood that delirium will occur. You need to be telling their family that delirium will occur. Patients with severe enough cognitive problems not to be able to sign a consent form will nearly always develop difficulties in coping with their ward environment, understanding what's going on around them in the post-operative period. And their family need to be warned about this delirium so that they can be involved in the multidisciplinary processes of trying to support cognitively impaired patients through the inevitable challenges of surgery. When you start talking about surgery, patients want to know the risks of it, and they want to know what their chances are. Some of them will have been told that they're not fit for a knee replacement, an elective knee replacement for their arthritis some years earlier. Many have faced complex discussions of other surgical options and been told that they're just not fit for surgery. So patients are often very frightened of anaesthesia and surgery. And they are often faced with junior surgeons, junior anaesthetists, telling them that this is a high-risk procedure. And that can be terrifying in itself. It's also nonsense. A high-risk procedure, implicit in that phrase, is that that's a high absolute risk of surgery. But what surgeons and anaesthetists means is a high relative risk. This is somebody who's frail and complex, who's at higher risk than a young fit person might be having the same operation. But that doesn't necessarily mean they're high risk. What is the risk of hip fracture surgery? Well, that's something we covered in this very simple paper in anaesthesia some years ago, and I think it's well worth looking at the conclusions from that paper. What we did was we used the ASA grading, the anaesthetic physiological fitness grading, because it's extremely conveniently available for all patients presenting with hip fracture in the UK. And what you can see is that though everybody and all the papers you read about hip fracture quote a quarter or a third of people dying in the year following hip fracture, of course, most of those people were going to die of their frailty, their other coexisting diseases in that year. The deaths in the period following hip fracture are much smaller in number. And in this graph, the dark line, the ASA4 group, is the worst 10% of our patients, the frailest 10% of our patients. And you can see that mortality in the month following hip fracture for that group of patients is only around 15%. For the fitter patients, it's far less than that. The grey dotted line is ASA5 patients. These are patients who the ASA grading suggests will not survive surgery or the next couple of days. And as you can see, the vast majority of them leave hospital as well. So the ASA grading is not a perfect tool, but it functions as well in this study as any of the other outcome prediction tools. And this picture of how mortality behaves on each day following the presentation with a hip fracture is, I think, really telling. So if you concentrate again on the ASA4 line, so the frailest 10%, these are the patients we worry about when we send them to theatre. What you can see is that mortality on each day in hospital is around 0.5%, and there's really an almost imperceptible increased mortality risk on the day of surgery. It's still 99% of this, the worst 10% of patients we see, and 99% of them will come back from theatre. So mortality following hip fracture is not due to anaesthesia and surgery. Anaesthesia and surgery are incredibly safe, and what needs to be dealt with are the issues of immobility and long-term comorbidities impacting on in-hospital mortality. So it's not a perioperative risk, and that can be hugely reassuring to understand that sort of figure when you're talking to family. And of course, if you are talking about risk of mortality and dying in the perioperative period, there is a question of, is it appropriate to start talking about ceilings of care when you're clerking the patient in? Now, during the COVID pandemic, I wrote this short article trying to explain to junior orthopaedic surgeons how to open the can of worms of ceilings of care when talking with their older patients. And in it, what I recommended was that for each patient they were seeing at a time when resuscitation processes were extraordinarily complicated at the height of the COVID pandemic, surgeons didn't need to be frightened to open the conversation about this. And the phrase that I use when I'm talking about resuscitation, it's a very nice, easy way of opening discussion, is just to ask whether patients have strong views about resuscitation, or to ask families whether the patient has strong views about resuscitation. Not asking, do you think she should be for? Do you want to be for? Not getting people to make a decision at that point, but just checking whether they already have strong views. Because the commonest reply I get to that is, oh no, I'm already not for resus, or she's already got a community not for resus decision in place that we didn't know about. So it just gives everybody an opportunity to open that conversation. If the patient wants to take it further, then fine. But in the perioperative period, I'm not keen on trying to make a decision, a complex ethical discussion of the pros and cons of resuscitation for somebody who's about to go to theatre. Because in practice, if we're taking them to theatre, we're giving them an atrial anaesthetic, decisions about resuscitation while the operation's happening in the intraoperative period should be at the discretion of the anaesthetist following their conversation with the patient. And I don't think that And if somebody comes to hospital with a pre-existing resuscitation decision, my general approach is to suggest that that should be suspended in the perioperative period. The anaesthetist is aware of it, but decisions about resuscitation in the perioperative period should be at the discretion of the anaesthetist. So that if an electronic event occurred in the theatre, the anaesthetist might consider cardioversion, even if they wouldn't consider this as being a person who's appropriate for a long-term ventilation. Really complex issues that might arise in theatre are not something that we should be prejudging on the ward. Thank you.